Bismillahirrahmanirrahim. Assalamu alaikum respected students. I am Dr. Muhammad Ansari, Assistant Professor of Pediatrics, and in today's lecture I am going to give a simple overview of acyanotic congenital heart diseases. Let's have a look on the human heart. Human heart is consistent of four chambers with major vessels arising from it. Right atrium gets blood from the superior vena cava and inferior vena cava, which is deoxygenated blood but nutrition rich blood coming back from the gut. This blood is deoxygenated, doesn't contain much amount of oxygen and need to be oxygenated in the lungs. Thus it moves from the right atrium to the right ventricle, and from the right ventricle it goes to the pulmonary circulation and it gets oxygenated, returns to the left atrium through the pulmonary veins, which are four in number, two returning from the right lung and two returning from the left lung. And from the left atrium, this oxygenated and nutrition rich blood moves through the mitral valve, comes into the left ventricle, and with the ventricular contraction it ejects into aorta and supplies the whole body with oxygen and nutrition. This is the frequency of congenital heart diseases. VSD being the most common, followed by PDA, then pulmonary stenosis, then coarctation of aorta, ASD, tetralogy of Fowler, aortic stenosis, transposition of great arteries, hypoplastic left heart syndrome, or hypoplastic right heart syndrome, AVSD, and truncus arteriosus. Pulmonary stenosis, the valve is stenosed. It can be valvular, it can be subvalvular, infundibular stenosis, and will require dilatation by balloon. By percutaneous intervention, balloon dilatation is required frequently if the pressure gradient across the valve is very high, like 64. If the pressure gradient is more than 64 mm of mercury, then it requires balloon dilatation. It requires intervention. Other than that, where it is seen commonly, there is a ejection systolic murmur heard in the left second intercostal space, but usually no intervention is required. Coarctation of aorta, there is narrowing of a segment of the aorta, which could be before arising of the left subclavian artery, or after subclavian artery, left subclavian artery. So there will be high blood pressure in the pre-coarctic segment. There will be high blood pressure in the upper limbs, and there will be low blood pressure in post-coarctic area. Post-coarctic blood circulation, like in lower limb, there will be low blood pressure. Atrial septal defect, there are two types, ASD primum and ASD secundum. ASD secundum is more common and tends to close spontaneously, whereas ASD primum is a bigger defect. It lies lower and anteriorly, and it is difficult to close and sometimes associated with valvular defects as well as with ventricular septal defect, and may constitute part of AVSD as well. So the symptoms are usually minimal and it resolves spontaneously, but sometimes rarely may lead to right-sided fluid overload and may lead to heart failure. Atrioventricular septal defect is most commonly seen in Down syndrome. It is also called endocardial cushion defects. There is a contiguous defect between the interatrial septum and interventricular septum, and it's a big defect which sometimes can be cyanotic as well, and has enormous symptoms even in infancy. Aortic stenosis, aortic valve. It can involve the aortic valve, can be subaortic, can be supraaortic. The aortic valve involvement in case of bicuspid valve is most common. If the valve is bicuspid, then the chances of aortic stenosis is very high. The murmur is heard in the right second intercostal space. There can be the murmur can radiate to the neck, and there can be thrill in the suprasternal notch. Because the ventricle is contracting against high force closed aortic valve, so there will be ventricular hypertrophy. There will be thickened ventricular wall. Uh, the ventricular aortic stenosis, if there is a click, then the murmur is probably arising from the is most likely arising from the valve. But if there is no click, there is only an injection systolic murmur, then it can be subaortic or supraaortic type. Hypoplastic left heart syndrome, the left ventricle is very rudimentary, very small. The wall of the left ventricle is thickened and poorly motile. Contractility is very poor. So the cardiac output is dependent on the right ventricular force, which is pumping to the pulmonary circulation, and return from the pulmonary circulation is deciding the cardiac output. And usually there is PDA or other cardiac defect which are maintaining the circulation. But unfortunately, because the shunting is going from the right to left side, so patient develops cyanosis as well. Uh, Although it is by at the time of birth it is acyanotic congenital heart disease, but it develops cyanosis later on, and patient presents with shock-like state, with poor perfusion, duskiness, because the shunting is going on from the left side of the heart to the right, from the right side of the heart to the left side. Because all these conditions lead to heart failure, so let's discuss little about the heart failure. Cardiac output is a product of ejection fraction and heart rate, or stroke volume, sorry, pardon me, stroke volume into heart rate. Cardiac output, when the cardiac output fails to meet the nutritional requirement of the body, this is called heart failure. Or failure of the pumping action of the heart is called heart failure. Pumping action failure can be of two types: diastolic dysfunction or systolic dysfunction. Diastolic dysfunction, when the myocardium fails to relax during diastole, and systolic dysfunction is called when the myocardium fails to contract during systole. When this back pressure is exerted on the body, on the pulmonary circulation, it causes different symptoms, which I'm going to show in the next slide. Because of the back pressure, there will be coughing, there will be pleural effusion, there will be pulmonary edema, there will be pulmonary symptoms, there will be easy fatigability, tiredness, shortness of breath. Pumping action of the heart is weaker. There will be hepatomegaly in children. Don't forget hepatomegaly in children. There will be abdominal fullness or abdominal protuberance. There can be ascites in adults as well as in children. There can be edema in ankles and legs. There can be sacral edema in a lying patient, and there will be puffiness of the eyes and face and plethora of the face in case of mitral stenosis. So these are all the signs and symptoms which you need to elicit in a case of heart failure. When heart failure when the patient keeps on developing repeated episodes of heart failure, and corrective intervention is not done, then the shunt will start to reverse. Instead of left to right shunting, that is oxygenated blood going into the deoxygenated blood, now the pulmonary side will have more pressure, and deoxygenated blood will start going into the left side of the heart and will cause cyanotic condition. There will be arterialization of the pulmonary circulation, and there will be high pressure. Pulmonary hypertension will lead to Eisenmenger, and child will start develop cyanosis, clubbing, and sign and symptoms like cyanotic heart disease. But the heart failure will settle. Heart failure will settle, but the patient is now irretrievable. The child will require heart lung transplant. Not only heart, but lungs will also have to be transplanted, because now the child has irreparable damage to the lungs as well. Thank you very much, dear students.